Good morning. We're here in Maui, Hawaii with Dr. Jennifer Loh from Fort Lauderdale, Florida. Thanks so much for being with us this morning.
Thank you very much for having me.
I know you gave a great talk this morning about cataract surgery in patients with challenging corneal conditions. Can you tell us a little bit of an overview about what kind of corneal conditions you encounter in patients who need cataract surgery?
Okay, great. Thank you. Great question. I think one of the most common and important corneal conditions we encounter today is actually dry eye. It's often overlooked and can actually lead to significant problems after surgery, including calculating for the wrong intraocular lens and also having the patient feel lots of symptoms such as burning and drying that they may feel that started because of the cataract surgery. Another common condition that we encounter is actually epithelial basement membrane dystrophy, and that, like dry eye, can actually also affect the IOL calculations and lead to myopic or hyperopic surprise and an unhappy refractive patient. And then the third main topic too of my talk is keratoconus, which is also more common than you would think.
Well, let's talk about the surface disease first, both in terms of dry eye and epithelial basement membrane disease. How do you counsel a patient who may have one of these conditions, or how do you adjust your preoperative measurements to account for those scenarios?
Well, in terms of dry eye, I really have to prep the patient and explain their condition. Not only that it's important to treat for their best outcome, but also for symptoms after the surgery. And it is tough, like you bring up a good point, because many patients come in wanting their surgery right away. They don't want to take the time or the effort to treat their dry eye, and they feel a little frustrated by the delay. So I do spend the extra chair time explaining to them that if we don't correct these conditions ahead of time, they may be unhappy with their cataract surgery. And usually patients are pretty accepting of that.
Well, that's a really good point. Let's shift gears for a moment and talk about keratoconus.
Okay.
Because I know there's been a lot of discussion in recent years about what type of IOL is appropriate for a patient who has, say, mild or moderate keratoconus. What have you found in your practice? Do you use monofocal lenses? Do you use toric lenses? Multifocal lenses? What kind of IOLs do you find you're using in those cases?
Okay, well that's a really great question too. I tend to stick with just monofocal lenses in patients with keratoconus. I do spend a lot of time counseling them as well that they will have to undergo probably scleral contact lenses afterwards, or RGPs, or possibly even cross-linking in order to really achieve the best visual outcome afterwards. But I think that toric lenses also can be a reasonable choice. It really depends on the type of keratoconus. If it's early mild form fruste, or is the type of keratoconus where it's still fairly symmetrical, at least in the central 2 millimeters of cornea, I think a toric lens could be a reasonable option. So you really have to just pick the candidate correctly, but I would most definitely avoid any kind of multifocal IOL.
One thing that I guess we have not yet encountered that we may encounter 5-10 years down the road, I suppose, are patients who have undergone collagen cross-linking who are presenting for cataract surgery. And the question is, will this become sort of a, another post-refractive kind of difficulty in measurement, or is this going to, do you predict that it will not affect our adjustments in the long term?
I think that it might affect the adjustments. I mean, usually when I've encountered patients with keratoconus, I do target a slightly more myopic result than I would normally because of the effects. And I do think that the cross-linking will change things in the future. However, at this time, I'm still recommending that the patient undergo cataract surgery first, just because if they have a cataract, at least it's something that can quickly help rehabilitate them a little bit, as cross-linking can take up to 18 months or even longer to really get any effect. And we're still not 100% sure at that time how much of effect it will have or in what direction. So but I think you have a great point. It will change things.
Well, those are really good take-home points, and we appreciate your discussing those topics with us. Thanks so much for being with us again today.
Thank you very much.